Thank you for the invitation and the warm welcome to the Gwalior city, Ravindra Bansal sir and the entire organizing team and the Prathamesh Pai sir. Coming to the lecture part, basically we are discussing about the role of ultrasound and the cross-sectional imaging when we talk about thyroid cancers and how it is relevant in today's era of guideline-based imaging. So first, keeping with the anatomy, if we see the anatomy, ultrasound is the first and foremost modality. It is used for thyroid nodule evaluation. It is used for risk stratification. It is used for the evaluation of the nodes in the cervical region. And it acts as a guidance modality for doing tissue sampling. And if we see that thyroid is a echogenic bright structure, means it is brighter as compared to the strap muscles that is here and as compared to the vessels that we see. Because of the multiple colloid areas, it will have a refractive surface and it will become echogenic. It will help in identification whether it is going into the surrounding structures and other things. CT scan is needed when we suspect that yes, probably there is an extrathyroidal extension, and there is a difficult evaluation when we are doing an ultrasound, whether it is a posterior or the inferior extent, and we are finding the elusive nodes that are actually not seen on the ultrasound and the ectopic tissues that are in the difficult sites and locations. So these are the two broad differences between these two imaging modalities. And what we have seen, the changes over the decade, is that it is one of the most common clinical conditions that we come across. There is a lot of overdiagnosis, probably because now most of these are actually incidentally find out by the ultrasound for some other reason, doing CT scan and the PET scan, and then we will see these things, leading to increased sampling and leading to increased surgeries. But what has not changed is the change in the imaging mortality, and probably that over these decades we are targeting these less aggressive carcinomas. And that is the reason that there needs to be some classification-based system where we can do a reasonable risk stratification to guide whether which particular. Thank you. Sorry for the technical glitch. So there is a need for doing a risk stratification, which nodules can undergo tissue sampling or not. And that's why this is one of the very few areas where we are trying to say that yes, there is a cancer, but we don't want to chase it. So if we talk about the role of radiologist, it is to do the risk stratification of the thyroid nodule, to determine the extent where exactly it is going, to evaluate the nodal and the distant metastasis, and to predict the organ of involvement, whether there is a need for intraoperative nerve monitoring and other investigations, and to do the post-op imaging and the active surveillance if it is required. So if we talk about preoperative neck ultrasound, so it is, we know that ultrasound is an operator-dependent modality, and it is difficult to evaluate the central nodes, and it cannot image the retropharyngeal, parapharyngeal, and the mediastinal nodes. What we need in the ultrasound is that there has to be a linear probe that is of having a 10 to 15 megahertz frequency, and it can actually image very well in the thyroid gland. What we have found out based on these guidelines that are given in the American Thyroid Association guidelines, that it can detect almost around 20 to 30% clinically negative nodes. So when the nodes are not clinically seen, it will identify metastatic nodal involvement in 30%, and that will alter the approach, the way we treat these malignancies in 20% of the patients. So that is something which is we learned from the ultrasound. And we can see in this particular patient, it was actually diagnosed as a thyroid nodule in 2021 and followed serially over till 2025. And we see that when we measure these things, the ultrasound measurements are going to be different because it is operator dependent. Somebody measure in some oblique plane, somebody measure in longitudinal, somebody measure in the cross-sectional, another thing, but the nodule architecture and other things are actually remain unchanged. And that is the reason that every time it is, though the measurements are coming different, it is a thyroid 3 category. And when it was sampled first time, because the patient was anxious, it was actually Bethesda 2 category. And again in 2025, the things will remain unchanged. It is Bethesda 2, but the patient want to have little bit of reduction in the size of the swelling, and that's why it underwent radiofrequency ablation. And we can see the post-ablation, there is no enhancement in the nodule, and actually now it is slowly shrinking in size post-ablation. So this was the pathology of this thing. And now we know that even if it is a papillary CA thyroid which is less than 1 centimeter, node negative, and there is no metastasis, these can be actually actively surveillance can be done, especially in the patients in which there is comorbidity and the older age is there. These patients can definitely be observed. Coming to another patient, if we see that it is a Thyroid 5 lesion on the ultrasound, and if we see the CT, there is a large lesion. It is difficult to know whether trachea is involved or not, whether it is involving the surrounding structures. There are a lot of metastases, vertebral, the rib and the sternum. And if we see the MR, we can see that there is no involvement of the trachea, neither the perichondrium is involved, neither the mucosa is involved. And this is the advantage of the MRI over the CT, where the soft tissue resolution is extremely high. This particular patient, when actually FNA'd, it has been labeled as Bethesda 3, and that's why the radiologist had to make a call with the pathologist that we are seeing this particular scenario, and then they have upgraded their Bethesda from 3 to 4. So this is how the multidisciplinary team will work in these particular sessions, and we will have regular MDT meetings in our institute. Here is Dr. Pai, and we will go into the pathology department, see ourselves what does it looks like on the imaging, it is seen on the pathology itself or not. Here again, it is a reverse has been happened. The resident has done the ultrasound. It is labeled as an Thyroid 3, but it's a mistake because it is a hypoechoic nodule, which is large one, and he thought it might be an isoechoic, and that composition has led to the translation. We got a call from the pathologist that they are seeing Bethesda 5 anaplastic CA, and if we see the CT, there is an extrathyroidal extension, infiltration into the surrounding structures, and it is updated to Thyroid 5. So there could be misclassification between different compositions, different echogenicity, and interpretation of these microcalcifications, echogenic foci, and other thing. That's why we need a system-based classification where we can actually give a numerical score, because we know that ultrasound is very operator dependent and the imaging interpretation is going to be different. So the American College of Radiology has given the Thyroid's classification. It is a lexicon-based classification because it is reproducible and it gives a clarity of the language. We can give a quantitative scoring system which have a numerical values, and it is purely on ultrasound features. We don't require the Doppler and other thing, and it will help us in designating between benign and malignant. And if we talk about, it will have a very high sensitivity and specificity. Almost up to 98% of the lesions can be called benign by this classification, and that is something which is very huge. The implications are that whether we need to, it gives a clear-cut guideline whether we need to do a follow-up or a fine needle aspiration, and also it gives a lot of confidence to the radiologist if they follow this classification. But what we have to do this thing, we have to adopt the protocol with the consistency. We have to educate regularly, do the training regarding these labelings, what are the indications why the patient has come, it is new or it is a follow-up, how the images are required, how the imaging interpretation is done, and whether it is lexicon-based or not. If we see from this particular aspect in the ultrasound, extremely hypodense and anechoic cystic-like areas having almost no chance of malignancy. As it is going solid, the chances of malignancy will increase in the thyroid lesion. Similarly, if the lesion is actually extremely bright, the chances of malignancy are very low. As and when it has become more and more darker, the chances of malignancy will increase in this nodule. Similarly, if it is very well defined, again the chances of malignancy are low. If the size is less and other features are there, and as and when it is having a infiltrative margin, the chances of malignancy are more, and if there is a microcalcification, it will increase further the chances of malignancy. So reporting these images have a numerical value, the values are given, we can go into the chart. Now there are calculator also available online. Once we know whether it is cystic or it is hypoechoic or it is anechoic or it is having this particular margin and that particular aspect. It will give a numerical score and we can decide based on that. People can confuse between the cystic degeneration in a multinodal goiter with a papillary carcinoma which is having a microcalcification. If there is a microcalcification, then it will indicate that yes, it is a cystic papillary CA, and that we need to rule out based on the imaging, and that requires a careful observation in these findings. If we talk about the cervical lymph nodes, cystic changes in the node almost having a very, very high odds ratio. It will give around 97% probability that this node is going to be malignant, even though if it is an intrathyroidal lesion which is of 1 or 2 or 5 millimeter, if there is a cystic node with a microcalcification, almost it is certain that it is going to be a papillary CA thyroid. And this has been labeled in ACR tirades. So if we go how we will advise whether the FNA is required or not based on these features. If it is entirely anechoic, nothing is required. If there are benign spongiform nodules like this or cystic degenerations having colloid nodules like this, again no FNA is required because the malignancy percentage in these lesions is extremely less than 2%. But as and when the suspicion, the darker areas will arise, and if the size is increasing, we will go from mild to highly suspicious areas. In a highly suspicious areas, we will try when the size is more than 1 centimeter, having hypoechoic and microcalcifications, then we will advise for an FNA. So whether the question will arise whether if we adopt this tirades classification, whether we will miss malignancies. So if the lesions are actually small, which are less than 1 centimeter, entirely intrathyroidal, not into the areas where it is in the posterior aspect or near to the trachea, then these lesions can be safely followed up, and we need to document how they are actually growing. If the growth is more than 20%, or if it is growing in 2 millimeter in 2 dimensions, or maybe the volume that is growing up, then definitely we will escalate whether it is fitting into the criteria of FNA. Suppose if the nodule is 6 millimeter, now it went up to 8 millimeter, but again it will not following up the criteria of FNA because FNA criteria is 1 centimeter. We will follow up these particular nodules, and if there are multiple nodules, we will measure the size of 4 nodules and only biopsy the 2 most suspicious one and see the laterality also if they are bilateral and in those aspects. And then there are various classification among the various continents and the countries, but more or less the features will remain the same. So the tirades is given the importance because it has advancing the technique in which the images are actually acquired. It will remove the inconsistencies in the reporting and giving more to the scoring system, and it will help us in performing more better biopsies and on-site biopsies, and it will also help us patients regarding what will happen to them if the nodule is 6 millimeter, whether they have to do a follow-up or they have to do an FNA. So the decision is a shared decision, and that can be communicated with the referral, whoever is actually referring, that these are the particular aspects and this has to be followed up. The reason is that the risk of malignancy and the risk of thyroid disease varies from region to region, and the tirades risk of malignancy also vary probably from the Gwalior to the TMH because we are having high chances of malignant referrals. So our tirades category might be different as compared to the Gwalior. So like in this particular nodule, it is a solid hypoechoic nodule with punctate echogenic focus, and it is seen in the midpole. It is not near to the danger triangle, neither to the trachea. So tirade scoring is high. Tirade category is 5. The size is less than 1 centimeter. Recommendation says that we can follow up yearly. Once the size reaches 1 centimeter or more, then we will try to FNA. If it remains the same for the 5 years, probably we can stop following after that. So ultrasound is the only modality in which we will monitor the progression. There is no other modality in which we can monitor the progression in the active surveillance. We don't use CT, we don't use MRI. It is only the ultrasound which will act as an modality which is in the active surveillance. Like in this particular case, where we know that it is having hypoechoic, there is increased vascularity. On elastography scale, it is actually an hard nodule and it requires sampling. Again, it is hypoechoic nodule, very infiltrative margins, vascular, hard on the scale, and we can see that this is the scale, this is the soft indicator, this is the H, that is the hard indicator, and is among the hardest nodule, and we have to biopsy from that particular area. Coming to the FNAC is actually important part of the diagnostic algorithm, and we should know the hardwares. We are using the spinal needles most of the time, and if the needle is accessible with a smaller needle, we will use that with the syringes. So the results of FNA is very, very operator dependent. Whether we are characterizing and targeting the true lesion itself, that is also important. What method we are using, what hardware we are using, whether we are using by the aspiration. We don't use aspiration because these are very vascular organ. Actually, we are targeting experience of the cytopathologist and the pathologist in evaluating these things. So orange needle, that is the best one, because only by capillary suction it will aspirate the cells. And if we are using a smaller needle, we will use the syringe, and we don't try to aspirate, so we can actually don't propagate the hemorrhagic areas into this. And this is how we are doing it as an Rose technique. So we take at least 3 to 4 passes per nodule. I will see how we are actually doing it. We don't apply suction, we will smear them, and we will do the Rose and then send it to the department. So there are different techniques. We can go directly, we can go parallelly, and this is the tip. Actually, we can see that is there in the nodule, and then actually we can decide it. So which area we are seeing more suspicious, we will target that particular area onto the imaging. Blind biopsies are actually, we don't do, because we can miss the lesion, whether we are into the thyroid, we are not into thyroid, we are into the hypoechoic area, which is the solid one, or the cystic one. It is better to have imaging guidance and targeting under that. And whatever guidance we are actually using it, we will try into the highest area, which is the most cellular one, and without suction, it will give a better tissue sample. We can use the Virling take in this. Actually, there is a very small lesion that is sitting there, and this is the heterogeneous parenchyma. We are trying a Virling technique, trying the center and the peripheral part of this particular nodule by the FNAC. Then what we do, we will put those smears, then prepare the slides, and actually do the Rose examination. We have the monitor here, which we can actually immediately see whether the sample is adequate. Similarly, if there is any doubt, these images are also related to the pathology department, where they can say yes. If there is any ambiguity with the cytopathologist regarding these things, they can tell us yes, whether the sample is adequate or not, whether we have to go in. Before we take the patient off the table, we'll make sure that we have find out the adequate sample for the patient, and the patient can safely send home immediately. These are the slides that we will see whether it is adequate or not in this particular aspect. If we are doing an FNAC, we will make sure that we don't have a different histopathology on the imaging. In this, we are suspecting that it is not looking like a routine papillary CA. We will ask them whether we can do the biopsy directly rather than doing FNAC, and we did the biopsy. It was actually sarcoma, not a papillary carcinoma. And in these other histologies where there could be lymphoma, chondrosarcoma, and other thing, we prefer to do biopsies instead of doing sampling. Coming to the cross-sectional imaging. Cross-sectional imaging, so CT is not a good modality to differentiate whether it is a normal thyroid, it is having a benign nodule, it is having a malignant nodule. It is only indicated when we are seeing that it is having an involvement in this particular aspect as compared to the CT. Similarly, if we see in this particular case, it is having involvement of the strap muscles. The planes are actually lost with the prevertebral fascia, but on the sagittal images, they are looking good. The tracheal cartilage